Keep presenting it. Ask them if they answer this. Oh no, you. Okay. Hello, student of Huye. Do you see this slide on the screen?
Yes.
Yes.
Okay.
Yes.
Okay. Now let us continue after the structure of the skin and its function. Let's go to this is not the reason. Let's go to the structure of skin lesions and fundamentals of clinical diagnosis. Now, I think we have to finish this before we have still time before lunch. Now, from the structure function of the skin, we have to go to the skin lesions and the diagnosis at a glance. Now, when we go to the skin condition has to be described and in a language that everyone should understand, which is a standard terminology. But before we can read this, a patient and thorough approach to the evaluation decrease the risk of making an incorrect diagnosis or overlooking another diagnosis. Knowledge and appropriate use of dermatological terminology are fundamental. You cannot recognize the skin lesions if you don't know its correct lesion and describing it in a good terminology, then this is fundamental. Recognition of a disease pattern requires repeated patient encounters. Of course, you may describe the lesion for the first time, you cannot retain it, but like me, I have seen in many occasions, for example, a tinea capitis. Its primary lesion. It's an example. The first time you can confuse it with other skin condition. Then you have to repeat to see and again see, just to memorize a condition as its primary lesion. Now, the history is indispensable in a CD complex diagnosis. Of course, the skin condition each skin condition has its primary region in all the rheumatological condition. But following different treatment the patient has done, or the condition has been chronic because of scratching, the primary regions is modified, isn't it? That's why you have to go to the good anamnesis. Taking history is very, very important. Okay? The entire mucocutaneous surface, as well as the hair and nails, should be examined whenever reasonable. There are those skin conditions where they have associated nail or mucous membrane which are affected. Of course, morphology characteristics derived from cells type in skin must be carefully scrutinized. Diseases have characteristic morphology and distribution. I think we will see everything below. Common pitfall in dermatological diagnosis exist and can be avoided. The diagnosis and treatment of disease that affect the skin rest on the physician's ability to use the language of dermatology. Okay? A lesion, dermatologically speaking, a lesion is a skin condition seen by a physician or a dermatologist. Okay? A lesion is a skin condition. When we say lesion, it's any skin condition seen by a doctor. That's why we say a lesion. Okay? It's important to know that and use to understand terminology as it's the first step in generating a differential diagnosis. Because some skin conditions, lesions, are similar, almost similar, then that's why a good description and use of a correct terminology is very, very crucial. It's also important to use a standard dermatology terminology for consistency in clinical documentation, in research, and in communication with other physicians. For example, if I do a transfer to transfer a patient, it's me who has seen first the patient. 10 days after, I may refer the patient to further treatment because the skin condition has changed because of the treatment I have made or super infection. I have to describe the patient regions using a good and proper terminology to help the other physician I refer this patient for further treatment to recognize the primary lesions the patient had. Okay? Now, this doctor said he who studies skin disease and fails to study the lesions first will never learn dermatology. This is true. You can't pretend treating a patient or know his skin condition if you don't study well the lesion. That's why when we do a biopsy, a skin biopsy, we have to describe the lesion so that a pathologist read and correlate the clinical findings with the histological findings. Okay? Now, when you go to the patient, of course, it's the dermatologist, of course, look at the patient in general, which means you have to see if the patient is ill looking, if he's obese, cachectic, or normal weight skin color. Because, for example, someone who comes with, he has a cellulitis, he's shivering. It means that the cellulitis he has or she has is complicated with sepsis. Okay? Then the patient may be cachectic because we have seen in some skin conditions where the primary lesions correlate with the internal organs affection, like in cancer. Internal cancers may lead to skin conditions, and then you may orient the physician and the dermatology. The dermatologist is the first one to see and to orient the patient to the oncologist. Okay? Skin temperature, of course, the region is warm, is cool, or clammy. Skin surface characteristic, dryness of the skin, excessive oil, seborrhea, hyper or hypohidrosis, excessive or decreased sweating, or to see the skin texture. The degree of photoaging, antigen actinic purpura, like in albinism, for example, they have these antigens or actinic purpura. Of course, you have to describe the distribution of regions. Is the region localized? Is the region Are the region grouped, regional, generalized, universal, symmetrical, sun exposed, flexural, extensor extremities, acra, heterogeneous, dermatoma, or follicular? All these have to appear if the patient has a region that meet this one of this distribution. Okay? Always you have to describe the region looking to its distribution. Okay? Looking to the aspects of the region, you go again, primary region, where you define it, the type. Is it a macule? Is it a papule? Is it a plaque? Is it a bulla? Or you describe the shape, annular region, arcuate region, linear region, and you have to describe secondary change. Because primarily, the region may be vesicular lesions. We have many vesicles or bullous, but because of scratching, it's super affected by Staphylococcus aureus. Then you have crusted regions, okay? Or because of the scratching, then you have excoriated regions. Now, you have to palpate because there are those regions which are palpable or not palpable. Okay? This is how you have to describe your region, primary regions, and then touch. And again, you have to see the color. The color may be whitish, okay? Whitish is depigmented or hypopigmented, or it may be black, like in melanoma. Melanoma is a black region, okay? Or lentigines. Then, in terms of color, again, you have to characterize your region. Then, you combine all together the aspects of the region to characterize it. Okay? Of course, apart to the region, skin regions that characterize the patients, you may have to go to vital signs, abdominal examinations, because some people may present hepatosplenomegaly in some skin conditions, and jaundice, for example, the pulse, okay? Lymph node examination, when a patient presents eczematous lesions, then a chronic itching. You have to palpate the patient, okay? Axilla palpation, okay? Crural palpation to see if there is not lymph nodes that may lead to malignancy. And characteristic of lesions, they may be raised, palpation, flat, not palpable, depressed. or to step up. Okay. In this condition, it's known that you have to rule out the the malignancy, internal malignancy, like ovary, for example, or the colon. Okay. Now, this one has been followed by some people who are not dermatologists, but we will know that this condition is most of the time linked with neoplasm condition. Then when we rule out, then he has a problem of ovary cancer. Okay, I don't know if you ask this, but it depends on the skin you have in front of you. If you have the skin, for example, it allergic contact dermatitis with general lesions, okay, you have many factors to think about if it is an internal organ involved or not. Okay, you may have itching without skin lesion, for example. Then what can you think? It may be diabetes, for example, because there are those kind of diabetes where itching is predominant. Then you have to rule out diabetes. It depends. Yes. Example, there are vegetable function. Each type of function. Okay, fungus. Okay. What's each one causes three reasons, but they cause three reasons. Since really, for example, I produce a kid when I have transplanting within regime and visit my field and that field is also have origin in use of hygiene. But I can also get something because of quality and the get experience in the countries and translate those people yes. One is a theory and another one is a experience. Clear understanding question. Because if it says animal, for example, it depends. There are those animals which are known to eat, okay? And there was superficial underfection, deep underfection, and system. The effect is it's always superficial. The contamination is highly contagious through contact from the person to another. When I use to share the same house, okay, or products, it's a very contact from the human to human, some person from culture like a cow to a human, or from the soil, geography, where is origin from the soil. What is okay? When out of conflict, human to human. What is different? Now, for system, for example, it's not osmosis. It's an example. It contains in dance. The droplets, the blood elects. Okay? That's when you this inoculation in the respiratory system. It's different. Usually, most of condition, they are not infectious. I think we will cover tomorrow. Yes, the infectious dermatological condition. So, it is not a system, it's generalized. Generalized skin protein or diffuse. It's different from the system. Generalized. Okay? That's by autonomy, by promiscuity by contact, physical contact. Okay. Now we have flat lesions, non-palpable lesion. Okay.
ikibazo prof
Yes.
ntabwo turi kumva ibibazo abanyeshuri biga ko bari kubaza kandi maybe we can also benefit from that rero ntabwo turi kumvikana neza
Nawe sinkumva ariko. Alo? Alo?
alo
Reka nzamure mikoro yanjye ndebe. Ariko mikoro yanjye irazamuwe da. Wari uvuze? Tu disais quoi?
nimze ntabwo turi kumva ibibazo like our colleagues from gako ibibazo bari
I was just explaining a question.
yeah
He
rero
was asking just a systemic in dermatological conditions, lesions. Just I was just explaining about this question, generalized difference between generalized lesion and systemic lesions. It's not a systemic lesion because it's a generalized lesion not necessarily be contagious or contagious, but it's in terminology we say when the lesions are diffuse, they cover the entire body. It's generalized lesion. It's not a systemic lesions. This that I was clarifying this. Okay. Yeah. Any other question? Now, flat and non-palpable lesion. The flat one, of course, is non-palpable, which is a macule, less than 1 centimeter, often hypo or hyperpigmented. It has lost its pigmentation, as we have seen. It may be hyperpigmentation because of a lot of melanin or increased melanin when it's hyperpigmented, or a lack of melanin when it's depigmented, like in vitiligo. What we can see here, it's seen only on the epidermis, okay? In macule, very important, the epidermis is not included, okay? The lesion may be hypopigmented, hyperpigmented, or depigmented in terms of color. You have to always characterize it by its size less than 1 centimeter in diameter, reside on epidermis, and differ in color from the surrounding. Okay, this is clear. Now, a patch is the contrary of the macule. It's a big macule, if I can say. Okay? More than 1 centimeter. Again, you have to characterize it by its color. Often hypopigmented, hyperpigmented, or depigmented. You may have in macule vitiligo, which is white, then depigmented, but a small vitiligo, but you may have a big macule known as a patch. Okay? Non-palpable. Now, second, raised regions or palpable. Okay? of course, they are elevated. It's a papule. Again, the epidermis is concerned, but the dermis not. Okay? But remember, the upper sublayer you see here, it's elevated. Okay? While in patch, it's straight. You see? This is a papule. Epidermis, located at the epidermis, elevated less than 1 centimeter. It opposes a plaque. Okay? Again, a plaque you see here. It's a big, what? It's a big papule. Okay? More than 1 centimeter, but it's very large. It's large. Okay? Again, it cannot seen on the dermis. Okay? Is it clear here? Then, and as a nodule, it's well circumscribed. Okay? The borders are well defined. Okay? But you see here, it is elevated. Okay? Even here. Okay? It's a big papule. Papule, like in acne, plaque, like in psoriasis, or recanified eczema. Okay? Now, a nodule. Okay? Don't confuse it with a papule. Look at the epidermis and you see? Now, a nodule is palpable, circumscribed as in a papule, but larger volume than a papule. Okay? Because it goes down to the dermis. Okay? And sometimes it may involve subcutaneous. Okay?
Question.
Yes.
Do you have some Kinyarwanda terms for this? Because many people are complaining ibibyimba. Are those ibibyimba or
Okay. Wese hari akabyimba gato n'akabyimba kanini n'ikibyimba. Ikibyimba ni tumor. Well, huh? Okay? Hanyuma a macule, a patch, n'amabara, if you can say. Okay?
okay?
You see, this is raised. It's a nodule. No, this is even a tumor. Okay? But important to see that the dermis and the hypodermis are involved. Okay? A will. Yes, please. There is someone who is asking me, the difference with a papule and a nevus. A nevus is a good example of a macule. Because ni umwana mu kinyarwanda wowe ndabibutse kariya kantu kirabura bafite umwana. Okay? But a nevus may be ikibibi. Hari akabibi gatoya, hari n'ikibibi kinini. When it becomes big or bigger than 1 centimeter, ni ikibibi kinini. It is a patch. But don't confuse the description and the condition. Okay? The disease description, a lesion, may appear in disease is an example. Then a nevus may be an example of a macule or a patch, but a black one. Okay? Urubara, vitiligo, you may have a small one and a bigger one. Okay?
Okay, and then what do people call isonono?
Please.
What do some people call isonono called?
Isununu is a papule. Okay.
Okay.
Because most of the time it's less than 1 centimeter.
Yeah. Okay.
Okay.
Thank you.
Now, another palpable lesion, you have a wheal. This is seen only in one condition known as urticaria. In Kinyarwanda, again, unyibukije, we may have a wheal, babantu bivuga ngo yaciriwe n'inzoka. Have you ever understood people say inachiriwe n'inzoka? Zamibe. Yes. The characteristic of a wheal which lasts like 1 or 2 hours is ni abantu bafuruta. Gufuruta. Okay? Then kiriya bita gufuruta niba ari umufuruta, I don't know. It's the consequence of gufuruta is a wheal, and it's seen only in urticaria. This is the example I have given. This urticaria, demographic urticaria, because this is have been made. If you scratch, you have raised lesions which will last like 1 or 2 hours. Okay, this is erased. Well, someone has, no, it's different. Urticaria may not be an allergy. Okay, just like 5% of urticaria are not allergic. Okay, but it may. Okay, allergy you have may have vesicles, you may have a bullous, you may have a plaque. Okay, and it itches. Now, palpable, non-palpable lesions, macule, patch, palpable, papule, nodule, a plaque, and a wheal. Now we go to the content of a lesion. Okay? We have, it looks, this one, a vesicle, looks like a nodule. Okay? The difference is that a vesicle contains a fluid, while a nodule is consistent. Okay? In size, it has as well less than 1 centimeter in diameter. Okay? And always it contains fluid. The fluid may be clear, serous, or hemorrhagic. Okay? According to the skin conditions the patient presents. Later on, this vesicle may rupture, okay, or may be superinfected to change the color. Then it's no more clear or serous or hemorrhagic, but it contains pus. Now you will have a pustule, okay, a vesicle, a vesicle, and a vesicle and a pustule. They are similar, but the difference resides in their contents. Because this one is a purulent. Okay? Okay? May become pustular, but this one, from its onset, filled with purulent fluid, a pustule. Okay? Now, Ebola. Huh? You see, it's bigger than a vesicle. Okay? It means that it's a big vesicle. Okay? the content is maybe clear, fluid, or filled with hemorrhage or blood, and following scratching, you may have a bullous, an erosion. Like here, you see? This is what we call bullous pemphigoid. Okay? Clear? Now, when a pistol is centered by a hair, it's no longer called a pistol, but it's called a folliculitis. Okay? Now, when a folliculitis necrotizes, it becomes a furuncle. Okay? The folliculitis is like a pistol centered by a hair. Okay? When the hair necrotizes, it becomes what? A furuncle. Clear? And always it's less than 1 centimeter. Of course, when several furuncle coalesce to form one unit, it's a carbuncle. Okay? Birumvikana? Is it clear from here? The abscess now, it's a localized accumulation of purulent material so deep in the dermis or subcutaneous tissue that the pus is usually not visible on the surface of the skin. Not usually, it's like this one. You have a slight elevation, while deeper, it's big. Okay? It's warm on touch. You have to touch to see if it's warm or tender or frict one when you touch. Okay? Now, lesions may be depressed. Okay? Erosions. Okay? A superficial burn. Okay? You see here, you have the upper layer of the dermis has gone. You see? This is a sheet of the epidermis, one sheet of the epidermis. Okay? Now, this is just an erosion. This is like in a superficial, the first degree burn. Okay? Now, ulcer. The ulcer, the epidermis has gone, the dermis has gone, and sometimes you go up to the subcutis. Okay? Atrophy or atrophy. Amaribor is a good example of atrophy, skin atrophy. It's by definition, it's a diminution in the size of the cell, tissue organ, or part of the body. But the good example is that when we apply abantu bafite amaribori menshi, striations is a good example of atrophy, skin atrophy, the epidermis atrophy, because there is a loss of the epidermis. Okay? Sinus. You see, you have small hollows where the pus comes from inside the sinus, and it is seen on the skin. There is a clinical example, seen hidradenitis suppurativa. This is typical when you have sinuses on axial areas or groins. Just as a dermatologist, you think about hidradenitis suppurativa. Okay? Again, striations is a kind of atrophy. Okay, it's the same. When you say striae or atrophy, for me it's the same. Okay, atrophy is a disease in dermatological setting. It's a nubwo abantu bamwe bavuga ngo n'ubwiza umugore wariboye umukobwa wariboye, isn't it? Barrow. A barrow is a way fed like a tunnel through the out portion of the epidermis excavated by parasites. We have a characteristic in skin ankylostomiasis called as larva migrans, or in scabetic boron, shishikara. It makes when a shishikara is scabious sarcoptes. It's a small and microscopic parasites which penetrate the skin because it's highly contagious by contacts. Then it creates a barrel, a tunnel, like here. Then when you scratch at this area, you may just observe it under microscopic examination, under KOH 20 or 25%. A barrel. When you describe this as a barrel on the skin, then a doctor always will think about scabies. Okay? Sclerosis is the hardness of the skin. In, for example, in scleroderma, like here, you have a hard wood skin. For example, just always it's seen in scleroderma or morphea. Then when in dermatology, when you say sclerosis, it's hard as a wood. Okay? And always the region is depressed and hard. Now, the primary regions may change following treatment, following environmental factors like scratching, okay, or by super infection with Staphylococcus. Then the primary region may change to the secondary region, okay? Now, when it changes, initially from exudative regions, the regions has exudations, leaving some fluids on the surface. Okay? Now, when this fluid dries, it gives desquamations. You may say scaling regions, desquamative regions, when you describe your regions. Okay? These are scales resulting from the primary regions. Okay? It's the same here. Hyperkeratosis. It's excessive cornification. Remember, in our upper layer, which was the upper layer of the epidermis. Yes.
Cornea.
Now, what is the upper layer of the epidermis? This layer, how do you call it?
Stratum corneum.
Yes, stratum corneum. Now, there is some in some regions conditions like psoriasis or eczema where there is hyperkeratinization with the turnover of keratinocytes grow like in 5 days. We have this. Then you have excessive cornification with thickened skin. Then this is what we call hyperkeratosis. Hyperkeratotic lesion, as just you described. Hyperkeratotic lesions. Okay. Now, crusted lesions. Crusted lesions. In some regions, initially, when you have secretions, like they are vesicles, they contain fluids, you scratch, the fluids dries, then you have crust. In this process of drying, then they crust, you say, crusted regions. And later on, because of scratching, it may be hyperkeratotic regions or be mixed. Of course, the color of crust are yellowish because of they are most of the time super infected with bacteria like in Staphylococcus infection. Of course, when you remove the crust beneath, you may have erosion, as we have seen, or ulcer. The good example is impetigo. Impetigo is a crusted, for example, in eczema. It may be impetiginized, crusted eczema. Impetigo, when you say impetigo, always think about Staphylococcus, okay? Like in this gentleman or woman. Now, following scratching, these are the marks of scratching because it's an itching region, like in urticaria, like in scabious, scabious. It's a result of scratching, then it leaves some marks. Then this is what we call excoriations. Okay? Always it's a result of scratching. Okay? Fissures. Okay? You see, when you describe here, the regions are, these are scales. Okay? You see? But here, you have this eroded regions, linear, which is a fissure. Okay? A good characteristic of a fissure in people who have fissure lesions, abantu bagira imyate. Imyate murayizi? Yes. In Kinyarwanda, mwe bazaga imyate. In imyate, we have fissure lesions.
Yes, and this is eczema.
Okay? Lichenification. Following a repeated scratching, the epidermis becomes thick. Then it becomes lichenified. Then you may say lichenified region. Okay? Because the region has been thickened. It's seen in chronic eczema, a result of chronic itching and scratching. Lichen simplex chronicus, it's just a chronic eczema, which have a plaque, like this is a plaque with scales, but which is hyperkeratotic and lichenified. Because all those components we may have all those components in one region. Okay? Now, keratoderma. Their accumulation of excessive scales, because we have thin scales and thickened scale. Okay? in this condition, we have hyperkeratotic condition with keratoderma, because this is seen in plantar keratoderma, in psoriasis, or in eczema as well. Okay? A scar. Huh? Don't confuse it with bed sores. The presence of a scar implies tissue necrosis, you see, as we see here. Okay? Infection, deep burns, gangrene, or other ulcerating process. It's an accumulation of adherent hard black crust on the surface of the skin that is moist initially, protein rich and vascular. Thermal burn. This is an example of a thermal burn. You see, there's the scar. Now, from this we go to purpura or vascular lesions, because sometimes on the skin we may have the vessels, capillaries, or the big vessels, like in varicose, prominent, or um, skin region made of vascular component. Now, this is a purpura, an example of vasculitis. You have extravasation of red blood from cutaneous vessels into skin or mucous membrane, result in reddish purple lesion included under the term of purpura. When you pressure, it does not disappear. Okay? Petechia. This is a small pinpoint purpuric macule. Again, macule because of the size of each one. Okay? It's purpuric patches. They are purpuric patches. Okay? If a region is purpuric and palpable, just a palpable purpura, the suggestion of an inflammatory insult of the vessel or as a cause of extravasation of blood and inflammatory cell exist. Here, when you press, it disappears. It's not like in purpura, which the pressure, the region remains. Okay? Petechia. Telangiectasia. You see? It's not linear, small linear capillaries. Again, it may be seen in those people who applies topical steroid or product containing hydroquinones. Okay? Telangiectasia. It's most common in female or with people who have a lower limb venous insufficiency. Okay? In fact, it's black. It's not vascularized. Okay? Infarctus. Just an example of is cholesterol amble. Okay? Now, from depressed regions, from vascular regions, we go to the shape, arrangement, or distribution of regions. You have characterized the region in its primary region. Okay? How it looks. Now, you have to characterize it, the distribution. Okay? Now, once a type of region have been identified, one needs to describe their shapes, arrangements, and pattern of distribution, all useful characteristic in morphological diagnosis. Now, a region may be a macula regions, but annually. Okay? A region may be a plaque hyperkeratotic annular region. Okay? You may combine those characteristics or those, okay? Like here, you see, this is the characteristic of granuloma annular. It has this round shape, like here in tinea corporis, igihusha, fungal infection, igihusha. You see, it have an annular region, but at the same time, it is hyperkeratotic. Okay? Now, or you might have a numeral region, eczema, like this one. It's not round as seen in the previous one in tinea corporis, but here you have a round or discoid region, like a coin. This is like a coin, but these have at one edge a round, a circular pattern. Okay? And at the end, and again, it is hyperkeratotic with some fine scales. Okay? A region may be polycyclic, formed from coalescing circles. This is the characteristic. You see, it looks like this. Huh? Many small circles are seen in this area, but they are multiple. Then, because we have a multiple circle-like regions, we term it as polycyclic. Okay? Now, arcuate is like a knot. Okay? Here, look at this one. Okay? Look at this one. This is arcuate. It's like a knot. Okay? It may be linear. This is the patient I have seen last week. With the region coming from here up to the right buttock here. This is a characteristic of lichen nitidus. Yeah? And again, this one is hyperkeratotic. We may say hyperkeratotic linear lesion. Then, or we may say hyperkeratotic pigmented, because it's black, linear lesion from the right foot up to the base of the buttock. Then someone may just immediately know the character, the diagnosis of the lesion. Okay, just it's like a line, like we see in here, and they are seen in this region, of course. Lichen nitidus time and lichen planus. Serpiginous, like a snake, like this. Larva migrans. This again, it creates a tunnel, but the tunnel, you may follow the tunnel like a snake path. You see, it has penetrated from here, and where the lesions is erythematous is very red. It's where the parasites resides. Now, or targetoid, you have concentric circles when the center erased region, like here, you see here, and this is seen most of the time in erythema multiforme or drug reaction. This characteristic to drug reaction. Okay. Now, we may go to the arrangement of multiple region again to characterize region. Lesions may be grouped. When they are grouped, they are called herpetiform. Okay? This one, they are grouped with the vesicles. They are filled with clear fluids. They have different size. Like here, this is a bullous, because this is small. This is a vesicle. You see? You may say grouped and mixed vesicles. That in your mind, you know the characteristics of herpes infection is herpetiform pattern or grouped vesicles. Now, this is herpes simplex. Okay, they are grouped like this one. You see, this is just the pen. Okay, grouped lesions, they are vesicles, and it's classic in herpes simplex. Now, you may have similar lesion which has no any distribution, but seen the entire body in another manner that's not characteristic here and there. Then we say scattered region. Okay? You see, just we are beaten here, here, here. Then we say scattered regions. Okay? But again, it's in the center we have a vesicles, it's erythema. You may say erythematous vesicular scattered lesions on the trunk. Distribution, you see, this is a herpes zoster zona. It follows dermatoma distribution, unilateral and lying in the distribution of a single spinal afferent nerve root. Okay, it starts here, then it follow this spinal afferent root. You see, this is typical for herpes zoster or zona. Then you may say zosterform region. You have bullous here, bigger 1 centimeter. You have the small one, okay, which are the vesicles, okay. Later on, these clear fluids will rupture to make fluid crust, okay, then to become crusted. Huh? Okay, this is exosteform or dermatoma lesion. Now, you have a brush coil. Okay, do you know brush collines? Huh? Brush collines. They follow brush collines only, and this is it's a typical, it's a rare syndrome seen in inflammatory Rhinea vericus epidermal nevus. You see how it follows the brush colline. This is typical for this condition. Okay. Now we may say generalized hyperkeratotic, because sometimes it's hyperkeratotic. You may feel it. Brachioid plaque. Just play with this terminology mixing. Lymphatic, lying along the distribution of lymph vessels, implies an infectious agent that is spreading centrally from an ocular site. When you say ocular, just this extremity. Usually a red streak along a limb due to Staphylococcus streptococcus ceretis. Now, A lesion, just it, may appear on sun exposed area. Okay, like in the feet here at the V-neck, on upper posterior trunk or upper chest. Because even when you put your clothes here, it's not protected. That's why it is sun exposed area. There are those dermatological conditions in photodermatitis. You apply your ointment, you have allergy because your ultraviolets make allergenic this typical ointment you have put. Then you have photodermatitis with on photo exposed area. You may say photo exposed or sun exposed, it's the same. The rest are sun protected area. Okay? Another terminology, you may say acra lesion, acra melanoma, acra eczema. Acra, you have hands and foot. Okay, extremities. Okay? And trunca, when they appear on the trunk. Okay? Now, extensor, flexor, intertriginous. Extensors, okay? This is characteristic on some disease like psoriasis, which is characteristic and which is a clue of diagnosis. If you have hyperkeratotic flex on extensor or on elbows in psoriasis, flexors, overlaying the flexors muscles of the extremities, the antecubital and popliteal fossa. Here, plaque on antecubital fossa. This is characteristic for atopic dermatitis. Okay? And it helps you to know when you have this localization to link it with atopic dermatitis or popliteal area. Okay? Now, when you have these lesions between web space, it's called as intertriginous. Okay? Maybe between the toes or fingers. Okay? Or we may have at this area axillary folds or groin folds. You may say this is intertriginous skin condition. Then you characterize it. Okay? A lesion may again be localized or generalized. Okay? You may say localized lesions with plaque, with fine scales or hyperkeratotic scales. Then you mix this terminology to make one sentence. Okay? And lesions may be generalized. The entire body without any space, it's a generalized lesion called as erythroderma. But it may be generalized but scattered. Okay? Yes. You see? Generalized but scattered here and there. Okay? And again, lesions may be bilateral. Okay? Lower limbs, upper limbs, bilateral, symmetric. Okay? It's like in the mirror, a image symmetry. as they say here. This is common in some conditions like psoriasis, because we have them here, or vitiligo. And then finally, when you have a region involving the entire body, like vitiligo, urubara, you know it, urubara. It may involve one portion of the body, the scalp, may involve the skin of my hand, but when it involves the entire body, you say universalis vitiligo. Okay? When the hair is, okay, we have a skin condition known as alopecia areata, where you have most of the time the hairs of the scalp, but it may be associated with the hairs of the rest of the integument. Okay, eyebrows, here, back, axillary hairs, and pubic hairs. There is no single hair onto your integument. Then this is universalis alopecia. Okay. It's just you can play in terminology to characterize, to describe the region, so that to make it understandable, if you have not seen a patient, if I just refer the patients to me, you describe well, I can even suspect the skin condition which has caused this topography region. Okay. I think we have featured the basics. If you have some questions, then go. Then we'll do some exercise in characterizing primary and secondary regions. Questions?
My question is about the photodermatitis.
Yes.
I would like to ask the autoimmune disease like lupus, which is associated with
Photosensitivity.
photosensitivity and the dermatology. How do you differentiate that photodermatitis with those autoimmune disease which shows photosensitivity?
Okay. Already we know the question is how differentiating photodermatitis for immunological condition and for non-immunological skin condition. This is the question. Now, we have some conditions which are photosensitive disease, like lupus erythematosus. We have lupus erythematosus without photosensitivity. Dermatomyositis, as we said, but we have other photodermatitis associated with, for example, allergies. Most of the time, you have allergy, you have, for example, you are atopic, you have asthma, you have allergic conjunctivitis, allergic conjunctivitis. Then, you know, these people, atopic people, are predisposed to skin allergy or to other allergy, food or drugs. Okay. Now, suppose you have allergy to vaseline. Let's take a simple example. Because vaseline contains glycerin, those people who may be allergic to glycerin. Okay. Now, because the glycerin is known for some patients to be photosensitive, or in atopic patient, when you apply, okay, you go to sun, the lesions will appear on where sun exposed site has village or that's why we see in some patient with photodermatitis, the lateral side of the arm are affected, the inner part no, because when you are protected from the sun, okay. It's different. There are those photodermatitis, those skin conditions known to be linked with sun. Even the lesion is triggered by the sun spot. Like you need to say sun. Okay. Any other question? Who here? No question. Oh,
Nakumva.
Yes, we are hearing.
any question? I want to give one exercise before. Huh? Yes. Biracikagurika sinkumva. Hello. Just wait a bit. I want you to stay a bit for some exercise. Uh-huh. Okay. Student from who? Do you see the image? Have you left?
Yeah.
Huh?
Yes.
Okay, Mugisha Ervin or Irvin. Huh? Remember. Mugisha Ervin. Ervin. Janet. Janet.
Yes, prof.
Where are you?
Abanyeshuri bagiye muri resitora I think ariko haracyariho bakeya.
Huh?
I think ko bamwe bagiye muri resitora ariko haracyari abandi bariho. Amasaha ya resitora yageze kandi hari ubwo nyine iyo mutinze musanga
Nuko mwiga
byashize.
dufunga classe saa sita n'iminota 15.
Ntitwari tuzi ko ari saa sita nuko mwari mwatubwiye.
Wowe uriho urabireba?
Biragaragara.
Urayibona?
Yego.
Okay, describe this nail. What do you see here? Just try to describe this. Reka mbaze mu
I think it is linear hyperkeratotic or linear pigmented.
the left one. What do you see?
I'm seeing that it's a pigmented breast.
We have two regions. Okay.
Yeah.
A big one, because I've said to you that regions may have different configuration, size, pattern. We have two type of regions here. See, John?
Yes.
The crusted
Yeah.
one here with this one. This area, for example, it's an area of hypopigmented region.
Yeah.
Centered by a crusted plaque. Okay, here.
Yeah.
And we have a two region like this, but the rest is this is the black one. How do you call it? This is a patch.
Hyperkeratotic.
No, the small regions are hyperkeratotic, but the smooth one here is
It's a patch.
hyperpigmented patch.
But yeah,
Hyperpigmented patch localized at the right hemi
wrist.
trunk. Okay.
Pectoral region. Right.
Uh, you know, you may just say hyperpigmented because it is black. You are going to say black. Hyperpigmented patch. Okay. Then you characterize the location where it is. Now here on the right one, this is a nevus, but that takes a linear aspect. What do you say? Linear hyperpigmented what? Region.
New.
It's a region. Okay.
Quite
Now the second one. Huh? What do you see? Okay. The round characteristic. What it suggests. Is it palpable? Yes. Then when it is a palpable, where margins were defined, this is an annular region. Okay. The
Can't you also
annular
exclamation? Can't you
hyperkeratotic plaque or scaling plaque. It is not hyperkeratotic. It is scales, still scales, but it's a plaque. Okay. This is a characteristic for tinea corporis. Now, this one, bigger than a nodule. This is a tumor. You see, it is excessive nodule. This excessive growth. Okay, this is a tumor. Okay. Now, what is this?
trias?
Trias. I know this patient, all those patients of mine, this patient was applying topical steroid, Mukorogo. She lives in Yamirambo. Then, because of, she came to me, she was using this mixture of hydroquinone and steroids. Then, you know, the skin is light, of course, but when you go to the fingers, it's black like yours. Then there's a striations, atrophy, okay? Skin atrophy, known as striations. This is irreversible, of course. She has to stop applying this. Now, what is this? Okay. Who here? What is this?
Gangrene.
Huh?
Gangrene as depressed crust.
Okay, it's mixed. When you see here, if you see the arrow here, maybe I see better on my screen. This hyperpigmented plaque with scattered ulcers inside the plaque. Okay? Because there's inside the plaque scattered ulcer. This is a characteristic of what we call pyoderma gangrenosum. It's very painful. Now, nta mukobwa urimo, mukobwa nasubize wihuye. This one on the right picture. On the right picture.
They are pupils.
Good. These are the characteristics of pupils. You see? This is seen in acne. Okay, in juvenile acne. And on the left, you see, they are scattered what? Keratotic or hyperkeratotic nodule, and it shows scratching much. This is what we call prurigo. Okay, now we can go for ranch, and let's meet here at 2. Then from 2 to 4, just we'll cover another topic. Then we go inside like eczema. Okay? Oui, vous avez entendu?
Oui, oui, monsieur.
Just we break for lunch. Then let's meet at 2 p.m. for eczema and related disorders.
Thank you, lecturer.
Okay, thank you. Bon appétit.
Merci.
You
Et
too.
vous?
Merci.